My name's Louise Savic and I'm an editor for Anaesthesia. It's great to have you both here today to tell us about this paper. Thank you very much for giving us your time. Eva, do you want to introduce yourself first?
Yes, hello everyone. My name is Eva Rooftoft and I'm an anaesthetist in a non-university hospital in the north of Belgium, in Antwerp. My specific interest in anesthesia used to be pediatrics. I still do it a lot, but it changed, let's say, 5 to 10 years ago to obstetrics more and more. And in that degree that I am doing a PhD on the subject, looking at an improvement in pain relief in labor and in cesarean section. And this last paper was one of my studies where I was working on with my PhD.
Okay, thanks very much. Mark.
Yeah, I'm Mark van der Velde. I'm consultant anesthetist in the University Hospital in Leuven, Belgium, where I was chair of the department until about 2 years ago, and I'm responsible for training of our trainees to become anesthetists of our university. My passion is obstetric anesthesia and obstetric anesthesia research, and so I'm involved in this study as in many others.
Okay, fantastic. Well, maybe to get started, could one of you just give us a rough sort of bit of background about where the gaps in the literature were that this study addresses? So what's the background to it and why did you feel this piece of work needed to be done?
Yes, so PIEB has already extensively been looked at in literature, and studies have shown that if you compare it to continuous epidural infusions with or without PCA, PIEB is definitely superior. So it gives less breakthrough pain, less motor block, a higher patient satisfaction. But we also know that continuous epidural infusion can lead to motor block, especially in long labors. And we also know that bolus volume gives a better spread. So that's why we wanted to compare two bolus techniques, so PIEB to PCA alone without a background infusion, and see if the superiority of PIEB still stands. First study, we compared it to a regular bolus volume of PCA, 5 ml, and PIEB compared to PCA alone, 5 ml, PIEB was definitely superior. Now we wanted to do a study where PIEB is compared to PCA, but in which PCA has the same high volume bolus as the automatic bolus in PIEB. So we wanted to compare 10 mils of bolus PCA to 10 mils of bolus automatic PIEB.
Okay.
And superiority still stands.
And just for anyone who's listening who hasn't maybe read the full paper, the PIEB, just to clarify, is a programmed intermittent bolus. So there's no continuous infusion in the background. It just automatically delivers the bolus. And PCEA is a patient-controlled bolus technique, again, without any continuous infusion. Yeah. And
just to additionally clarify, in both groups, the patient could get patient-controlled boluses. Also in PIEB, they could get additional boluses, but the total volume per hour they maximally could get was similar and the same in both groups.
Okay, great. So Mark, what would you say the key findings from this study were? What did you find?
Yeah, so it was a non-inferiority trial with respect to breakthrough pain, and we found non-inferiority of patient-controlled epidural analgesia as opposed to PIEB. So if you give a high volume bolus, you can achieve with PCEA, patient-controlled, you can achieve the same results in terms of pain relief as with a PIEB. We even found superiority of the PCEA technique with respect to local anesthetic consumption. There was on average, for a total duration of labor, 15 milligrams less use of ropivacaine. And this stood if you did an intent to treat or a per protocol analysis. So that remained the same. All the other variables were similar between the groups, except for the fact that in the PCEA group, there was more interpatient variability than in the PIEB group.
And what would you attribute that variability to in the PCA group, patient-controlled group?
Well, if you take away the background infusion and you only get pain relief by pressing a button, you get a bit the waxing and waning sometimes of analgesia. So patients wait until they feel pressure, and after a couple of, after some time, they really know what to expect when they feel the pressure coming, but they always get a bit of pressure and then they press the button for pain relief. So whereas in PIEB, where you have these preemptive bolus, because you have every hour an automatic bolus, you often do not have these fluctuation in pain relief. Although in PCA, our pain scores were low, and the same as in PIEB, there was a little bit of fluctuation along the lower scores because they mentioned 1 or 2 on some time basis because they waited to press the button when for pressure to come.
And when you spoke to the women afterwards, because you looked at satisfaction scores immediately after delivery in 24 hours, did the patient-controlled bolus group, who had that slightly greater variability, albeit at the lower end of the pain scores, did they report lower satisfaction? Did that correlate to feeling less satisfied? As it did it matter to patients?
Not at all. No. So
okay.
They were all very satisfied. We had the same satisfaction scores at 1 hour after delivery and at 24 hours after delivery, and they were very high. So there was not a difference. I think that women, they don't matter if they feel a little bit of pressure, if they know how to handle the PCA, which is a very important point when you use a patient-controlled epidural analgesia, that you explain to the women how it works, and they do not have to wait too long before they press the button when pain comes through. If you do that, they were all very satisfied.
Okay.
And low pain scores mimic that, because we had very low pain scores in the PCEA group as well.
And do you think, I mean, you mentioned this in your discussion that the patients who had patient-controlled boluses, because someone was coming to review them every hour, they were part of a research team, everything's much more tightly controlled than you might have on an average very busy labour ward unit. How much impact do you think that might have? I mean, as in real life, do you think you would see the same, you'd see more variability and perhaps greater pain scores and less satisfaction?
Yeah, that's a potential problem with this study design, because you can't do, you have to check every hour. That was in the protocol. But I think if a patient is comfortable and pain-free in the PIEB group, she would still get a bolus, even when she's asleep. However, in the PCEA group, when she's comfortable, she's sleeping, she's relaxed, nobody's disturbing her because the labor is progressing normally, she might suddenly become awake when there is pain, and she would run a little bit behind. She has to press the button. It will take 15 minutes before she will be pain-free again. We're pretty sure she will be pain-free again, but she will at that point report slightly higher pain scores probably. So that is that is the issue. If you would implement this high-dose PCA in real life practice, you might see this, that in some patients, not in all, but in some patients, you might see suddenly much higher pain scores. Briefly, they will respond to the bolus, but they might be there. While here we sort of prevented this by waking them up, and they started to feel something, they pressed the button, and then everything was okay again.
There was one time point, I think, was it 240 minutes, so about 4 hours, where there was a statistically significant, not necessarily clinically significant, difference in pain scores, and most of the variability in pain scores does seem to have come beyond the 2-hour point. What do you think accounts for that? Why would there be more variability you know, as the epidural, as the labor progresses, than at the beginning?
Well, in the beginning, both groups were started with the CSE initiation. So usually for 90 minutes, more or less, you don't have pain. And then patients or start to press, or the PIEB is already going on. And then, of course, labor progresses. And then you will see that, well, when labor progresses, that the pain will also alter, and that they need to press more. But we still had only 1 point, although the average of labor was more or less 6 to 7 hours, if I recall correctly. We only had 1 point at 240 minutes, which was clinically significant difference. Whereas in the other hours, 5 hours, 6 hours, it was not the case. So, and as you mentioned, well, it was statistically significant, but was it clinically relevant? I don't really think so, because the score was still 2 or something.
Yeah, it's still very low. Yeah.
And I think it really coincides with the spinal component wearing off.
Yeah.
I think that's probably the most important reason. And in the PCEA group, they are again lagging a little bit behind, but the spinal component is wearing off and they have to press the button. And yeah, it's 120, 150, 180 minutes. Here it seemed that the spinal dose worked a little bit longer than yeah, but this also might be due to the fact that you take a select group of patients instead of the normal clinical mix of multiparas, etc., etc.
So it's a combination really then of that variability later on is both just the intensity of labor increasing and the spinal wearing off. So it sounds as if there's a learning curve for the patient control group then, that they're comfortable for a period of time, and then they need to, what you're seeing in those first, you know, from around the 4-hour mark onwards is a sort of steep learning curve perhaps. So then in units which don't routinely cite a CSE, but just put an epidural in and load that up, might you expect to see greater variability from the onset of the epidural? Do you think that learning curve will be moved?
No, I think it's the same. I think maybe you will have a shift from time points, but the learning curve is still, for me, remains the same. Women needs to know or need to learn which pressure is well, which
which sensation of that predicts now I'm going to move on to pain instead of feeling something. Yeah, and they are pain-free with the initial epidural bolus dose. For a period of time, and then it will reappear. In the PIEB, it will not reappear because the pump gives something. In the PCEA group, there will be a moment or two that they will, this is what it's going to feel like, I have to press.
But as you say, all the pain scores stay very low. Although there's greater variability, the pain scores are all, you know, there are slightly wider confidence intervals, but they're still all around the, you know, VAS score of 20, you know, which arguably is, you know, for most women going to keep them comfortable. So for a jobbing obstetric anaesthetist working in a unit somewhere, would you say to them the take-home message is we should be providing patient controls epidural boluses or programmed infusion bolusing?
Well, we still feel, I think I can speak for myself and for Mark, that PIEB is an excellent maintenance technique. We both use it in our hospitals as a standard technique. The message we want to give is, well, if you have women who want to be actively involved in labor, then PCEA alone with a high volume bolus, because we have shown that low volume or a standard volume is not enough. You need to have a high volume and so a low concentrated solution. That might be an option in that small, or maybe in that subset of patients. But well, we both think that PIEB is an excellent way. It gives a very good pain relief. It gives none or very low motor block. It gives a very high patient satisfaction rates. But we just wanted to show that if you use PCA, you should use it with high volume boluses and not low, because the spread is what you need with PIEB or with PCA. So, and that's the message we want to give. We think that it might have a place for a subset of patients, but for the majority, we think that PIEB is excellent.
And do you see any limitations to the programmed intermittent epidural bolusing? Are there any potential risks associated with that weren't picked up in this study?
Yeah, we have seen a couple of case reports in the literature already looking at wrongly placed catheters, which weren't cited at first, that they were spinally placed, for example. And then if you have an automatic bolus every hour, you can end up with a total spinal if you don't see the alarm signs rising up, because they will appear, but you need to see them. Whenever in PCEA, where your patient really controls the button herself, without an automatic bolus, you will not see that problem that much. Not that you see it in PIB that often. It's very limited, I think. But I'm not sure that these safety issues are already well known in the literature for now.
I mean, if for instance your catheter is intrathecally, one PIB bolus will not result in a total spinal. It will result in a high block, but it will also result in a motor block. And if the motor block is present, then there should be an alarm sign for midwives to alert the physician to come and check the patient. I think these guidelines were actually published in anesthesia on high blocks and what to do with high blocks in laboring patients and epidurals in laboring patients. And the key role for motor block evaluation is extremely important. So it is with PIEB. I mean, 12 milligrams of ropivacaine, as we were using with PIEB, will not result in a total spinal. It will result in a high block, perhaps some hypotension, and a motor block. And that is something that needs to be picked up. So if anybody introduces PIB in their clinical practice, they should instruct very clearly to the midwifery staff to evaluate and follow this up. The same, by the way, with PCEA. If this 10 milliliter bolus would be injected intrathecally, you would see the same result of it. But here, if it isn't picked up with PIB, the patient will get a second bolus, and that might result in a high or total spinal. While with the PCEA, she will be completely pain-free and will not press the button. So that, I think that's an important thing. It will be a very rare thing, but certainly we need more evaluations and studies to see how frequent it might occur. It hasn't been reported that often, but it certainly can happen.
Yeah, and the risk with both, of course, is the same as with any epidural, that if you top it up for theatre, I mean, you know, that risk exists equally across both groups. So there's no benefit in either group. So just thinking in the UK, there's certainly and elsewhere, there's been moves to reduce the use or abandon the use of nitrous oxide, and the corollary of that seems to be an inevitable rise in the increase in the number of epidurals that are used. Do you think either of these techniques are equally suitable, or are you really saying that if it's patient-controlled epidural bolus, you're more likely to need more input from a midwife? So possibly, you know, as epidural usage increases, will our midwives be stretched too thin, perhaps, or do you see that as a potential problem?
You mean with the PCA alone modality, yeah? Because PCA with background infusion has been.
Oh no, sorry. I mean, yeah, without a background infusion.
No, but I think that the same learning curve maintains. Although I think that midwives come in at least once every hour to check the patients, especially after you place an epidural. You have a closely monitor for a certain time of period, and then at least in my hospitals, they come in on a regular base. But then you have these patients, if you have a patient who comes in the evening because she's induced, well, they usually sleep a bit in the night. And if you then give a PCA alone, then you might get into trouble, because these patients do not press buttons, they fall asleep. And then what Mark already mentioned, they wake up because of pain. So making those patients, it is not ideal. But in a subset of patients, who really sometimes are a little bit afraid of epidurals because they fear of side effects, and they really want to manage their epidural their own. They want to control their analgesia to their needs and not feel nothing, which sometimes is the case in a PIB, especially in the first period of labor. Well, in those patients, this PCA might have a place. And I think that after this learning curve, as we already mentioned, they really know when to press, because they know what to expect, how long they can stand this pressure before becoming uncomfortable. And then they know, now I'm feeling this, now I'm going to press, and I keep comfortable. So I don't really think that there is a huge increase in workload of the midwives. I really don't think not in PIB and not in PCA alone.
And I mean, in our hospitals, the epidural rate in Belgium is very high. It's more than 80%.
More than 80%.
more than 80%, and your hospital might even be higher.
Okay.
And our midwifery staff is certainly not more than in the UK. I think we have one midwife per 2 rooms, 2 patients. So they are not constantly with them, but they check them every hour. It also depends on whether this patient requests an early epidural when labor is not really advanced, versus somebody who requests it at 6-7 centimeters. And then I think in that last group of patients, for me, PIEB is even more ideal, because you only have 2 to 3 hours usually of labor before they deliver. 2 or 3 boluses of PIEB, the patient doesn't have to bother, they're quite comfortable. While in early labor, you might get 10 or 12 PIEB boluses before you deliver, and then PCEA might be more suited. But again, it's patient choice, I think. What I would do is offer both modalities and let the patient choose.
Yeah. Okay. Okay. And then just the last question, I think that's probably all we're going to have time for. But if you, well, not if you would do the study again, but what would be the next piece of work? What do you see as the next study following this?
Well, we already mentioned it as a little bit of a small flaw in the study because of the involvement of study personnel. Every hour, we might influence the results. So if you really want to see how those two compare to each other, we need to do a clinical practice study, so a real world study where you compare these studies next to each other without every hour monitoring the patients, just monitor the if there is breakthrough pain and monitor patient satisfaction, but not on an hourly basis, and just leave the patients as they are, and then you will see the actual well, actually what study personnel involvement really does to announce these the results of the study. So this is something we might do, but then we need a lot of patients and a lot of time. But it would be a very nice study to really.
It would be fantastic. Yeah, a real world example of what you've shown. Fantastic. Sorry.
No,
Mark.
I just wanted to add, and I think with outside the scope of this study, but looking at PIEB, we should look for complications in a sort of registry of everybody's using PIEB. How many high blocks do we see? How many issues with catheters do we see? I think that's also important, and that needs to be a big registry with thousands of patients involved, I think.
Yeah. No, I agree. That would be very useful. That's a big piece of work, though.
Yeah.
Just the right people for the job. Okay, thank you so much. I think we'll have to end there, but thank you very much for your time. So great study, and I'm sure everyone will be reading it avidly any moment now. Okay, thank you so much.